and then most important, the chief guest, CRE, and other treatment options. So what is MDR? So multi-drug resistance is frequently defined as bacteria resistant to at least one agent from at least three different antibiotic classes. So the problem is so severe that in actually 2017, WHO has categorized some of the resistant bacteria as high priority, for which they need antibiotic very urgently. So CRE and most of the MDR GNBs, they come on category. So if somebody wants to save lives, or somebody wants to change the world, or want to have a Nobel award, definitely there is a scope for research here. So why the MDR is more important in liver transplant recipients also? Basically, in pre-transplant patients, there are some limitations. Like they have in cadaver, they have long waiting time. So they have to go to health facilities repeatedly. Because of that, there is exposure to healthcare system, and repeated antibiotics also they are receiving. So that is a limitation. And post-transplant, obviously, it's a complex procedure. It requires, immunosuppressive therapies, and it is necessary invasive interventions are also there, like say central venous catheters, urinary catheters, mechanical ventilation. And one other important thing is sometimes donor also can transmit such kind of bugs. Cadaveric donor. So if cadaver donor is positive, is having sepsis, or his blood culture is harboring is showing something, definitely you need to be more careful. So just going from the basics, I think this is a nice slide. We all remember Anant Krishnan's book once we see this. So gram positive. Gram also was a wonderful person. Actually, this person has invented this gram stain during his residency. But there are other sources also which say that he invented it in Berlin in 1884 when he was working in morgue. The most important thing what Graham has done is he has published that innovative technique. That is the key thing what he has done. And while publishing, he has written that, this is not an infallible procedure. There might be some problem, but it will at least guide people for future innovations. But I think this innovation has lasted more than 100 years with the same technique, and it has actually the whole classification upon that. So coming to the point that gram-positive bacteria, we are more bothered about cocci. So in that aerobic cocci, which either is streptococcus if they are catalase negative, or catalase positive, they can be staphylococcus. In that, if coagulase positive, it becomes a Staph aureus. If coagulase negative, then they have a saprophyticus and epidermidis. So we are mainly bothered about Staph aureus, and then gram-negative bacilli. So if the stain is purple, then it's gram-positive. It's red, then it is gram-negative. So bacilli is like rod-shaped organisms. So in that, if they are lactose fermenting, they are fast, then they are E. coli, Klebsiella, Enterobacter. If they are slow, then they are Citrobacter, Serratia. So, and if they are non-lactose fermenting, in that oxidase positive, then here comes our other organism is Pseudomonas. So after this basic thing, let's go towards the MRSA. So in liver transplantation, it's quite common. It's around 4 to 23% of transplant recipients, they have organisms. Most important thing about them is there can be a nasal carriage for this organism. So, the patient may carry in the nasal mucosa. So if this is the case, then it is a high risk for infection. If it is pre-transplant, it increases risk for 6 times. In post-transplant, it increases the risk of MRSA 11 times. So, and what are the risk factors for those? It's like prolonged ICU stay, patient having SBP, CMV infection, broad spectrum antibiotic use, and donor-derived MRSA. As we all know, vancomycin decomplaning can be given. Important thing here is if vancomycin MIC is more than 1 milligram per liter, it is better to avoid vancomycin and directly shift to linezolid or daptomycin. So the other method is like, can we decolonize them? Is decolonization is going to work? So problem with that is that most of the patient would be on the cadaveric donor list. So how many times you're going to do decolonization? What is the frequency, and which regimens we are going to follow? That is not clear. So currently it's not recommended. So then if it is resistant to vancomycin, then it becomes PRE. So unlike MRSA, primarily it is associated with the exposure. So patient has to have health facility exposure or exposure to the organism. Prevalence is also quite common. It's 12% in pre-transplant to 16% in post-transplant. It's about colonization. So if the patient is having they are colonized with the VRAs, there is 7 times higher risk of getting infection. So what are the other chances? Like patient is having biliary complication post-transplant, if you're getting any bile leak or any biliary issue or any intervention like percutaneous drainage you're putting, I think it should upgrade to the antibiotic which is covering VRAs. So which are the organic antibiotics? We know rapamycin, linezolid, teicoplanin, and if it is resistant to all this thing, this is the newer one. It is tidazolid. So here comes our chief guest of the lecture is MDR GNB. So worldwide, more than 50% of the post-transplant recipient they have infection GNB. Total of the 100%, 50% is caused by the MDR GNB organisms. The risk factors include re-exploration, abdominal infection, and ACR, acute cellular rejection or acute allograft rejection. So if you have anything of this, definitely we should upgrade to the antibiotic, which should cover them. So in that category, first one is the extended spectrum beta-lactamase producing E. coli or Klebsiella pneumoniae or GNBs. So why they are special? Because they're able to hydrolyze beta-lactam antibiotics. So what are the beta-lactam antibiotics? So these are those beta-lactam antibiotics. So basically, if the patient is ESBL positive, the organism is ESBL producing, that means penicillin, cephalosporin. So that means penicillin, cephalosporin, first 3 generation, and sometimes monobactams. They are out of the question for the treatment. So that is issue with beta-lactam ESBLs. So then they are recovered both in the community and the healthcare settings. The rates of ESBL infection vary from 5.5 to 13% near about in post-transplant patients. But the issue here is the mortality, which is as high as 40%, and that too on appropriate antibiotic therapy, which is not good. So there may be multiple reasons for that, but still the total outcome is not good. So once they are beta-lactamase producing enzymes then we have to shift to the carbapenems. So what are the risk factors to have ESBL? Recent history of SBP, recent receiving any beta-lactam antibiotic or advanced liver disease, and repeated explorations. So what is the treatment? Obviously, most of the transplant centers, they start with the meropenem only, along with the gram-positive like coverage of teicoplanin. So important thing to remember here is if you have a blood culture showing ESBL producing organism, it is better to avoid piperacillin, tazobactam, and cefepime and for a severe infection, or the patients who are immunosuppressed, where the chances of recovering are less because they don't have that much. However, if it is a urinary tract infection, so if you have a GNB in the urine, which is ESBL, then maybe you can go ahead with the piperacillin. And obviously for all GNBs, I think contact precaution is necessary. So then this is the major concern, that is carbapenem resistant enterobacterus, CRKP. So of those, it can be E. coli, Kleb pneumonia, but most worrisome is also Kleb pneumonia. So there are 3 types of mechanism by which this resistance is transferred. So of them, the most common is the producing carbapenemase. Just like ESBL, they produce a carbapenemase enzyme which dissolves or hydrolyzes the major. So in that, let us go to the classification. So CRE, so it becomes a little bit complicated, but we'll just simplify it. So if you have a CRE, that means carbapenem resistant enterococci, which is commonly seen nowadays. Like you have a Klebsiella pneumoniae, which is resistant to everything except colistin. So they are classified in 2 types. Either it is carbapenemase producing CREs or non-carbapenemase producing CREs. As I told you, there are 3 types of mechanism. So one is producing enzymes like carbapenemase. So this is that. And the other thing is they can have efflux pump or porin mutation. So this is one of the same type, but the hydrolyzing enzymes are different than the carbapenemase. According to this, they have class carbapenemase producing CI. There can be different mutations. There can be different mechanisms. So this is KPC. This is the most common. Why it is important? I'll just tell you first that why it is important. So this is one of our patient's report. So she had Klebsiella pneumoniae in her bowel. So culture isolate from the bowel showed Klebsiella pneumoniae, which was resistant to everything except cholesterol. So we have done gene expert carbar on her. So that gene carbar expert shows report like this. So IMP1 not detected, WIM, NDM not detected, KPC not detected, but OXA48 is detected. Okay, so that is the important. That's why we need to know what is OXA48. So now, once we have the CPCRE, if you want to classify which type of organism it is, we have to do carbar testing. So after you do carbar testing, you will get to know which is the type positive for it. So importance of KPC is it is the most common CRE. It was first detected. Nowadays, it is seen all over the world. It is the only enzyme which has caused the pandemic. A true pandemic in Greece, Latin America, and United States. So that's why this is important. So treatment-wise, the good thing is that they respond to polymyxin and colistin. So they have actually the CPCRE are classified into 4 groups. One is A. A group is this is in the light gray color. So KPC, IMI, and GES are in the A group. B group is MBL. MBL means metallo-beta-lactamase producing, and then OXA48 like. So this is dark gray. So this is D. So only C type is missing, but the clinical importance of it is not very much known. So that's why we are bothered here about KPC, MBLs, in MBL, NDM, VIM, and in third one, group D, OXA48 like. So as I showed, they have also cartridge for these main common enzymes. So once you are positive for MBL, so what is the importance of MBL? They have a horizontal transfer, but they are sensitive to monobactams. That means you may be able to start aztreonam. So if the patient is positive for WIM, IMP, or NDM, aztreonam may work. But nowadays, what is the issue is that there are these organisms are associated with ESBL producing organisms also, mechanisms also. So because of that, they hydrolyze monobactams also. So nowadays that is also becoming the major issue. So in MBL, NDM is New Delhi metallo-beta-lactamase. What is the importance? Actually, it was discovered in 2010. There was one Swedish patient who came to Delhi. He got treated here in one of the Delhi facilities, and then he went back, and then they diagnosed him to having NDM. So then now there are multiple types for that, NDM1 to NDM5. The problem with NDM is that they are resistant to newer beta-lactamase inhibitor also. So they are resistant to quinolones also. So like gentamicin sometimes is sensitive for some CREs, but you won't be able to use in MBLs. So in NDM, and then aminoglycosides. So newer agents, neither older agents you'll be able to use against NDM. However, VIM, which is Veron, it was invented in Veron, discovered in Italy. So that's why it is named as Verona integron-borne metallo-beta proteinase. And second one is IMP. IMP is imipenem resistant pseudomonas. Actually, these are the name they are given that initially they were found on that organisms, but they are now seen across the species, across the different classes also. So like KPC can be seen in E. coli also. And this VIM or IMP can be seen in Klebsiella pneumoniae also. The third one is OXA48 like thing. So OXA48 like it's a club. Like means it's a club of six types of organisms. So in that OXA48, the importance of it is that no existing inhibitor works against them. So that is an issue. So which inhibitor is like beta-lactamase inhibitors, and they have extraordinary capacity to mutate. So this is also a current concern. And then others are not that common, which come into clinical practice. So these are the. This is a very nice diagrammatic representation that how they have introduced the carbapenem and how the carbapenemas are also got detected. As soon as they have introduced, the sooner or later the carbapenemas has got detected. So this is IMP, which is imipenem resistant pseudomonas, which was in Japan. It was discovered in 1990. And then there's KPC in 1996. So meropenem was introduced in 1996. However, the same year you see that KPC also was discovered. So these are different things. And then NDM was discovered in 2010. So why CRKP is so much important? The reported rates of CRKP in liver transplant ranges from 6 to 13%, accounting for 23% of total bacterial infections after liver transplant. But the biggest concern is the mortality ranges from 18% to 80%, which is too high. Like for high milder, it is like a death sentence. So if you have a patient more than 32 mild and he gets a MDR Klebsiella infection, there is high chance he will die of because of that infection. So, and colonization is also very much common in those liver transplant recipients. So, in one of the Italian study, they have written it's around 4.6% pre-transplant colonization. So, what is the importance of colonization? Definitely that you may be able to upgrade your antibiotics offhand only. So, as patient is colonized with CRE, that means that during transplantation, your empirical antibiotic should include CREs. Otherwise, your day 3 culture may come positive, and then that time it might be delayed thing to start with the antibiotic. So what are the significant predictors of subsequent CRKP infection? Obviously, one is the colonization pre-transplant. Other things are if the patient having advanced liver disease like mild more than 30, patient having HCC, low and anastomosis, post-operative any major issues like biliary lake, re-exploration, then patient requiring dialysis or prolonged ventilatory support, and then recurrence of hepatitis C virus. So how do you treat CRS? This is the most controversial thing currently. So there is no antibiotic which provides universal activity against CRE. The available agents we have is aminoglycosides, polymyxin, colistin B, and polymyxin E, that is colistin, and polymyxin B, and then tigecycline. So in the settings of cystitis, you may be able to use fluoroquinolones, fosfomycin, or nitrofurantoin. So, but the major debate is surrounds around the use of polymyxin, their uses, their dose, and still, emergence of resistance on there. So, how do we decide? So that we have newer agents also, ceftazidime-avibactam, which adds to the arsenal definitely, but there is no reliable activity against MBL, which I told you, like New Delhi metallo-beta-lactamases. They are resistant inherently to this ceftazidime-avibactam. So, and this resistance is now transferred to KPC also, which is quite worrisome. So then we have a newer aminoglycoside, which is plasmicin, which may be used for MBLs, and intravenous fosfomycin. Some center, including our center, we also use it quite commonly. So, what are the treatment options? Basically, there are 3 treatment options. One is use old or antibiotics. Second, use combination of the 2. And 3 is use newer agents. So, how do we use old antibiotics and what options we have? So, commonly, as I told, one is the fosfomycin. The limitation is resistance. Aminoglycosides, again, there is a resistance nowadays. Colistin, luckily, this resistance is not so common, but that is also an upcoming thing. But the issue with the colistin is obviously nephrotoxicity. So you can use polymyxin B instead of colistin, but the issue with that is it is not good for the urinary organism. So if you're targeting urinary GMB, CCCRE, you'll have to go ahead with the colistin. And tigecycline. So a newer thing with the tigecycline is using a double dose. The biggest limitation with the tigecycline was there is a low concentration in the tissue, mainly in the pulmonary tissues. So if the patient is having ventilator-associated pneumonia, which is positive for CRE, then the use of it was not, there was no obvious mortality benefit. However, in some recent studies, they have used a double dose tigecycline. So you give a 200 milligram stat dose followed by 100 mg dose, which is the double dose of a routine thing. And they have shown that 70% of the bacteria, 70% improval in the survival as compared to before. So that is a good thing. Now, what is the dual therapy? So that is also one nice thing about this is combination of carbapenems, which is called dual carbapenem or double carbapenem therapy, in which what they do is you start the patient with the ertapenem. After the ertapenem, you start with the meropenem with a longer duration, like 3 to 4 hours of infusion, and then you start the patient on 2 gram 8-hourly meropenem, either meropenem or toripenem. So this dual carbapenem therapy is also, has been proven effective in most of the studies. So the basic logic behind is that the ertapenem is called as the sacrifice antibiotic or sacrifice therapy. So ertapenem sacrifices itself for this beta-lactamase. Is not at all useful, but that beta-lactamases are utilized by that ertapenem. So as soon as they are utilized, you just send a second army, which is meropenem, so that the recovery of the enzyme will not be there, and it will act as a bactericide. So that is one of the good outcome therapy. So other things are ceftazidime-avibactam. As I told, the resistance is also, but this is a non-beta-lactam, a beta-lactamase inhibitor. So that is a good thing about it. And then the and Weberbactam. So other novel drugs are plazomicin, iravicycline, imipenem, rilibactam. So not all drugs are available here. Most of them are in the current clinical trials, and our major issue is that we don't have so many clinical trials going on so that we can try. So this is a small simple chart because most of the times things get complicated, and at the end of lecture or at the end of the seminar you won't be able to find that what you have learned. So this simple thing will help you in knowing that how we have to target, because these are the 5 major things we are going to get in our common clinical practice. This is from a review article from Hand et al., which is a very nice article actually. So in that they have shown, so this ceftazidime-avibactam, it doesn't have any sensitivity against MBL, so including NDM, VIM. So this is the common indication. Otherwise, they have written a cycline. So the example which I gave you in my previous slides, that the patient who had a cleft pneumonia in her bath and positive for 48, she was started on ceftazidime-avibactam for 10 to 12 days of therapy. At the same time, what we have done is we have done a sensitivity for tigecycline. We can do an intrinsic sensitivity test for specific antibiotics. Like you have sensitivity for ceftazidime-avibactam also, fosmicin also, and tigecycline also. So it was resistant to tigecycline, and that's why we didn't use it. So is there any role of eradication if the patient is colonized? So if you do stool swab or swab and you find out that the patient is CRE positive. So there are some studies that have used oral gentamicin and oral polymyxin E, and they have got very good rate, which is in initial. So it was published in 2013, that article, which was quite discussed also. However, the subsequent analysis, there was an increased resistance to the colistin gentamicin also. So I think it acts as a double-edged sword. It has to be used judiciously. So there are other common organisms of clinical significance are multi-drug resistant pseudomonas. So in that, it is quite common, 6.5% to 10%, and all more than 50% are MDR in that organisms. So both ceftazidime-avibactam and tazobactam, they do demonstrate activity against this organism. However, neither novel cephalosporins or beta-lactamase inhibitor combination fits MDA. Then the plasmocin, which is like I said. Another which we quite afraid of is the Acinetobacter pulmonale. It is also, I mean, if you're getting a sensitive Acinetobacter, it's a very good thing in your body, but most of the times it is resistant, and it is resistant to 25% as per the literature, and the same experience we have. It is associated with the mortality rates over 50% and 90% in the ICU. Combination therapy with collagen and carbapenem is used. I mean, we don't have any other option. I think most of the times you have to hit hard with the collagen rather than polyamine. So, and ampicillin sulbactam, surprisingly, it shows the best activity against CRA, which is, I mean, older drug, but it's old is gold sometimes. So, newer agents, neither ceftazidime, avibactam, nor cefazolin tazobactam, they demonstrate any activity against. So that's why in such cases, so you should not be in the impression that, okay, this is a newer agent and it's going to work for all the organisms. Unless and until we know their basic characteristics, it is important. I mean, it is important that when we are de-escalating, when we are escalating. So in conclusion, most of the bacterial infection are early, I mean, happen early phase of the transplant, which is like initial 2 to 3 weeks. There are device-associated infections. So in the transplant, you have to do a fast-track surgery. Like fast-track is starting from the intraoperative period. So as soon the lesser the time transplant, it's good. The less is the exposure. Removal of the devices like urinary catheter, central line. So as soon as you feel that they are not required, their use, they have, I mean, their purpose is solved, then I think you should. Possible. Early mobilization helps definitely for multiple things, including there is decrease in bacterial translocation, decrease in pulmonary atelectasis. So that should be done. Universal bathing with the chlorhexidine. Some of the studies they have done that patient daily after the transplant also undergoes bathing with the chlorhexidine, and they have shown a good benefit. But to recommend it universally, it is not up to that stage now, but I think it is worth a try. Early and appropriate antibiotics, which is, and it's a political statement, so but it has to be decided according to the local policies also. And the empirical broad spectrum therapy. So this is also vitally important. And now for transplant, these things are changing. Like the patient who's low MILDR, patient's MILD is 20, is getting cadaver donor transplant, you maybe get away with piperacillin tazobactam. So our routine empirical therapy for a transplant was piperacillin tazobactam with teicoplanin and fluconazole. So, but as you are getting a sicker patient, I think this thing is not valid for that, because they are already exposed to most of the times meropenins, I mean beta-lactams and meropenins. So carbapenems also. So you have to go. I mean, for empirical broad spectrum itself, you have to be on the higher side. So if the patient score is high, like MELD score is more than 32, patient is having encephalopathy or any other major issues, patient had a history of renal replacement therapy, or patient may require that thing, CRRT. So in those cases, I think for empirical antibiotic therapy, we prefer to have a teicoplanin, polymyxin B, and meropenem. And followed as soon as, so as we have a protocol that as soon as patient goes for a transplant, before going inside the operation theater patient, we send blood culture to sets, aerobic, anaerobic. Once the patient comes out of the transplant operation theater and is received in the ICU, we again send a blood culture set. Then we are sending blood culture on day 3, which is follow-up blood culture, so that we get a report after day 6 if the patient is still harboring some organisms or not. And so on day 3 culture, we will be able to decide that should we de-escalate or escalate. So in a nutshell, if the patient is having suspected bacterial infection, nowadays we may be able to consider that it may be a MDR, because it is becoming so common. But still, depending upon the condition of the patient, where the patient is admitted, I mean, if it's a ICU care, and also endemicity of the hospitals, because in some of the hospitals, CREs are endemic. So you have to decide your empirical antibiotic therapy according to that. So you have to, according to that, you start your empirical antibiotic therapy. But the most important thing you have to find is the source control. Is it a biliary issue? Is it a leak somewhere? Is it abscess, or it's organized hematoma which is getting infected, or is it a basal atelectasis has got infected? Is there a consolidation? So in every round, every time, whenever you see the patient, you have to think about the source control. Today, if you are not finding, maybe tomorrow you might get some clue. But unless and until we do the source control, it is not at all useful to just go on doing empirical antibiotic therapy. So or any antibiotic therapy. So once you do source control, then the penetrance, the outcome of the antibiotic is good. So for that, you have to go ahead with the imaging and aggressive, and you might require daily X-rays, or you may require multiple CT scan, which include HRCT, maybe CT abdomen. But we have to go ahead with that. So there is a terminology also in a transplant that is called failure to rescue therapy. So failure to rescue means any post-operative course of a patient is, I feel it's like a PSLV satellite. So once it is launched, you can see the trajectory, how it is going. So if at all it is deviating from the trajectory, you will obviously come to know on the screen. And undoubtedly, that is not a good sign. So in post-transplant patient also, if you feel that the patient is going away from the trajectory, so that is the time you have to rescue patient again to the same trajectory, until they are in their orbit. So once they are in their orbit, then they are on their own, and most of the time they don't require that much vigilance. But before that, so till the time they go into their own orbit, you have to be quite vigilant, and you have to rescue them if they are deviating from the trajectory, which is called rescue therapy. So failure to rescue means you're not able to rescue them, and once they are deviated, they are just going down. So unless and until you do audit and you find out that, okay, this patient was deviating from his trajectory now, and then he should have done this, he should have done that. So once you do the audit, then you'll come to know that what is the failure to rescue rate. So if and how you are going to improve the rate. So that is a good terminology. Regarding now the after empirical antibiotic therapy, once you will be getting culture over 2 to 3 days. So if the culture is positive, you have to treat accordingly, and don't bother to don't afraid, or don't worry about doing the higher investigations. You should do it for ESBL or CRAs. So if you need a CARBAR gene expert, it is better to go ahead with that, because a single antibiotic cost is also going to be the same of the single investigation. So in our hospital, the cost of CARBAR is around 7,000, 5 to 7,000, and almost it will be same in most of the centers. So if they are culture negative, so then we are at the square one, but still you have to decide upon your clinical judgment that which antibiotic you have to continue. The most important problem which happens in the current scenario is the de-escalation. Like we have started patient on meropolypi and tigecycline or teicoplanin, and now day 3 culture is not showing any gram-positive foci. So should we stop teicoplanin? So ideally we should, but still unless the patient is comfortable and there are no major issues, every transplant surgeon physician would be happy to de-escalate it. But that doesn't happen always, and there might be some issue if which is because of which we have to continue. And most of the times, these antibiotics are continued till 5-7 days. So here, this is the point where we'll have to work out more. So, thank you very much for the patient listening.